marathon in the walking together, that they called us to call me Inui to call us to treat a child who had a how you say
Shortness of breath.
Shortness of breath. They had a chief complaint. So we entered together. We used to walk together with children. We entered together and we started to do his physical exams, like pediatrician exams. And I looked at, with the child. She had problems of psychosocial problem, like from the community we knew it. And then he started to ask her, and he said to me, I think she doesn't have an asthma. Her biological mechanism is not comprehensive to suit for that biological trauma. And I said, but Uri, she's dissociated during the conversation. And this was in the beginning of our walk together. And he looked at me and he said, how do you know that? And I'm coming back to your lectures about, and I studied in Tavistock in UK, and in that moment, I looked at myself, I looked at him in this medical setting, in the Department of Pediatrician, and I said, as much as trauma is doing split, we are doing, as practitioners and professionals, doing the same split between body and mind, or body and emotional, I would say emotional, and we walking separate, and we missing so much together, because we can then we understood that there is something in between physiological and between mentally. There is some, I'm calling it like the circle of the Audi, you know, the Audi car, the Audi circles, like, you know, the Audi symbols. So this is the thing that we have together, and this is what we wanted to start from now about the medical somatic dissociation.
Okay, so at the get-go, we had evidence of high prevalence of...
Is it both walking? Yes. You can go.
So at the get-go, we had high prevalence of, we knew there's high prevalence of child abuse, but only a small number of children were diagnosed, actually. We talked about it a little bit yesterday. So we are searching for a useful screen. We searched the literature and didn't find any good screens. So we started to think, how can you get it? How can you get to it? We've talked about abuse being a lifelong disease, so we have an economic burden, which is really huge. In 2008, almost $124 billion spent in the US, directly and indirectly, because of abuse.
And we always said that he amazed how much medicine investigate in like MRI, CT, all this examination and checking and millions of, like he said, 1,000 child, and the root is the abuse, but everything, like how we invested so much money and spending so much money on trying to find out with medical examination that the child abuse is sitting in the roots of the problem.
So we've talked about a little bit about symptomatology yesterday, about the physical sides and about the mental sides, and how they're all fruits of child abuse and neglect. But these are the kind of complaints we see, and that they'll go all over. You see many, many specialists and spend these dollars this way. Okay, this is one of the ways. We also talk about the Münchhausen by proxy, which is called today medical abuse also. But if you think about Münchhausen by proxy, until you say stop with these tests and etc., the child goes through a medical abuse, a very prolonged medical abuse. But he does that also if he has abdominal pain, because he'll do. It's much easier to get a colonoscopy than getting a a diagnosis of child sexual abuse. I've seen teens and older teenagers in surgery because they don't go to pediatrics, they go to surgery, but they'll have a laparotomy before they'll talk to them. And I tell my residents, if everything else fails, go talk to your patient, okay? If you don't know what he has after the laparoscopy, then go talk to your patient. Because one of these women, she had a known history of child sexual abuse, and yet when she came with her abdominal pain, no one put these things together. She'll have her colonoscopy or laparotomy or whatever. So we need to think about it. So again, we've talked about the symptoms of abuse. I'm not going to repeat it today. There we go. But here, again, we split it to physical and psychological, okay? And it's always split in the literature. I should be taking care of this, and this is for the psychiatrist or the social worker, okay? We're not doing it together. For the abdominal pain, you don't go to a social worker. You come to a doctor. And for your depression, you probably go to a psychiatrist or another kind of therapist, but not to your doctor most of the time, or many of the times.
And I want to add that usually when clients come to us, or patients or children who come to us in school, they have that. But we, as a mental health practitioners, we will come and treat them here. But we cannot neglect and split, because otherwise we're splitting the whole body. And always I'm saying to the student, Freud spoke about ego, id, superego, all these things. I didn't see that. I can see nose, I can see face, I can see stomach, I can see leg. Everything is a consumption. Like, we think of that, but who said so? But the body, we neglect the body, and as mental health, we need to rethink about integration. So, I cannot see the... So, we knew that all of you know about dissociation. Is it clear here? No. So, but everyone know here about dissociation, but we love this quote from Carol Gilligan that she's speaking about dissociation. So dissociation is the shock, trauma is the shock of the psyche that leads to dissociation. The ability to separate ourselves from part of ourselves, to create a split within ourselves so that we can know and also not know what we know, feel and not feel what we are feeling.
So we started looking for a screen, we started looking for available tools. What are the tools available there? So we mainly found research tools and not clinical tools. And these research tools were usually used for defining disorders. Okay, when we look about dissociation, about dissociative disorder, they're good for the disorder, but they were not good for like feeling the climate or trying to scale things or trying to look at the symptomology. So this was one of the main problems. The other main problem is that we also love to do it as doctors, is binning. Binning, as Shir put it with veterans from the Vietnam War, is when I see a patient, I want to bin him. What's binning him? I want to put him in a box and say, you are dissociated. You have a dissociative disorder. Or you are depressed. So we need to treat depression. I don't look at him as a whole. I look at a small part, and then I just throw it into the bin. Okay? And we do it a lot. And we like doing it because it makes the world more simple. It's more simple to bin someone than to actually look at the whole thing. So we're looking for something which is more descriptive and less diagnostic, so as a screening tool.
So then when we started to look for a tool that can relate to what happened there in the field, like we're sitting in the field, we are working in the ER, in the department, at the pediatrician department. So we thought about, okay, all these tools for disorders, something is not fitting. We're looking for symptomology symptoms. So this is interrelated to Rachel and my PhD, that women who've been sexually abused in the childbirth, they didn't have, no, sorry, that women who've been sexually abused in the childhood, that they came to labor, they had symptoms of distress. They didn't have disorders, because this, like we're speaking about most of the women who've been abused, they are common women who's having children, 98 of them were married. So the thing is that we are looking for symptoms and not disorders, and all the scales were for disorders. And we're speaking about dissociation, usually we're speaking about mentally disorders or mentally symptoms, and we're speaking about about DES, and in Hebrew it's HDES. We're speaking about PDEQ, that it is peri-dissociation symptoms, it's on the moment, on the present. And then we found out that there is a SDQ-20. This is somatic dissociation questionnaire of Van der Hart and Nijus. I don't know exactly. I'm saying it in
Nijus.
Pardon? Nijus. But still, it's rooted in the disorders and not symptoms. And this is where we looked for symptoms for children who've been abused to do screen.
Also, we were looking for something that in the medical setting, people could ask. Okay, I cannot ask about dissociation in the medical setting. I can ask, but not directly. So we have a case presentation here. We have a 15-year-old. Her chief complaint was syncope. She fainted. It was a long faint. Usually after a faint, they rise immediately, but she was lying there for hours. Her physical exam was normal. And what I did was I used with her a questionnaire. I used the SDQ-20 actually, and I saw that she's really dissociated. But again, I wasn't feeling good with this kind of questionnaire. But what the questionnaire led to is a direct question. Because if we'll take all the patients with syncope and do a screening like the questionnaire we're going to present, so the ones that are positive, I'll go forward and I'll ask them a direct question about child abuse. Okay? So I asked a direct question, and she said no. And then she went away, came back to the ER after a month, because we leave what we call an open door. I tell her, you may not be able to extract it from your memories now, but if a memory comes to mind, you can come back here. So she came back and said she was sexually abused, and then we sent her to treatment. So we'll talk now about the current research. So we've created a new questionnaire, which was laid. We used our clinical questions with a little bit of guidance from the SDQ-20, and created a new questionnaire. We wanted to do research in adult and in children. So in adult and in children, we validated this questionnaire. With adults, we could also ask direct questions about prior abuse. So we've correlated, we tried to find correlations between child abuse and the questionnaire.
Can you explain about the children about the ER?
The method for the children was that we've recruited them inside the ER. So a child between the ages of 10 to 16 that came in with any kind of complaint was offered to participate, and if he approved and his parents approved the participation, then he got an iPad and just answered on the iPad. It took them something like 10 to 15 minutes. We'll show the whole set of questionnaires in a minute.
It's set on the same basis of Triana,
Okay, so for the MSDQ, we set 4 experts, and we're talking about this dissociative disorder, and build the questionnaire from our clinical knowledge. So the MSDQ is, we have 30 items. It's a Likert scale between not at all to very much. We've grouped the questions into several areas. One was psychological, physiological, and dissociative. And examples are, do you have chest pains? Do you have difficulty breathing? Do you go to one place but find yourself in another place? Or are you drawn to sad things? Okay.
So we divided the tour. Oh, can you go to the next slide, please?
Yeah.
No, no.
Prior slide?
The upload here. No, the other one. No? Here.
Yeah. Okay.
So this, I think it's a better slide. We use different questionnaires. With the children, we use SDQ 20. It's a somatic dissociation questionnaire. PDQ to find if there is a dissociation. BSI, depression scale. It's divided to 3 subcategories: somatic, depression, and anxiety. Then we could see correlations. And the MSDQ, it's 30 questions, and now it's 26. With the adult, we've done SDQ 20, PDQ, BSI, MSDQ, CTQ, it's a child traumatic questionnaire, and LEC, it's PTSD, according to the DSM-5. Life event. Life event questionnaire.
I just have to say that for the SDQ 20, what we did first, that we took a group of children, 150 children, we gave them the SDQ 20, and we asked them, after they filled it, we asked them to translate it into their words, because some of the things that were written there, children could not understand them, and we wanted to use a childish, or more childish, or more appropriate language. So we changed the language in accordance to what they said, so it'd be more child-friendly. We'll talk about it.
Yes.
Okay, so for the adults, with the adults, they've got the questionnaire through the internet. Okay, we've gathered them, introduced them randomly. We had a male to female ratio of 30 to 70%, more females. Ages was 18 to 75, average 35. 13% were Arabs, because we took the questionnaires, also translated them into Arab and sent them to the Arab population. We had 15% with chronic disease and 20% of saying that they were diagnosed with ADHD. With children, it was 100 children, more males than females. Ages were 10 to 16, as I said. And chronic disease was a little less prevalent, but ADHD was more prevalent. Which is more or less is what you know about.
Yesterday, what we said, and then you said about external and.
So look at the Pearson correlations between the new MSDQ to prior questionnaires used like BSI, SDQ, and PDQ. You'll find that the correlation is high, but also that the numbers that we've got for adults and for children are very, very similar. Okay, so correlations were good. If you want to look at it graphically, so this is MSDQ for children with BSI, and you can see that they really go together. Okay.
So it's correct with depression.
Well correlated with depression.
Somatic and anxiety.
And as for predictors of what goes with child sexual abuse, so in adults, child sexual abuse was more prominent in women, 32% to 10% in male, okay? It was statistically significant. For about the education, so it was a little bit, there was no difference, in education, okay, academic or non-academic. There were less people from the child sexual abuse were less married, more than were not married. okay? They had a tendency towards chronic disease, okay? And they had more ADHD. We've talked about ADHD yesterday, so this was really significant.
And I want to repeat, our goal was to do practical guide for medical and also for mental health, that there won't be any question about child abuse, that it will be, that we can give it to children in therapy session, in the medical session, and then it will be can hint on trauma and dissociation that came from the roots of trauma and abuse. So we going back up like a bottom up. Okay, you understand the goal of like our thinking of.
So in here, the numbers for adults. So these prove that there is a good correlation or a bad correlation, a good correlation between child sexual abuse and the MSDQ questionnaire as a total score. And if you look at each score of the 3 parameters, each one stands for itself. So, just to conclude. So we're looking here, we think it's a promising practical tool that we can use as a screen in the medical settings, but we're starting to think that maybe it could be used in other settings. I have to say that the questions some are more like, do you have abdominal pain? Do you have chest pain? Do you have a dry mouth? Do you feel tingling under your arms? And some are more, do you go to one place and find yourself in another? Do you go to take one thing and find yourself taking another thing?
You're sitting in a class and you don't remember what was told in the class. So this can hint on dissociation also.
So I have to say that I ask the questions. It doesn't matter if it's from this part or this part. When I ask them in the same manner, in the same tone, and they react in the same manner. So we get really good or not good answers, but we get really direct answers, because what I've seen that if someone else asks them, many times he'll get a straight no for everything. And that means that the child didn't connect to him. We talked about attachment yesterday, therapists and where it works and doesn't work. So, but when they use an iPad, they're more direct. It's more easy because it's not as biased as when I ask them or someone else. So it's a very good way with children, and children love iPads. They wanted to take the iPads also, We couldn't. So we're thinking it could be suitable for other settings, education system, mental health, etc., etc.
And in relate to what happened yesterday, we spoke about therapy. Are we tailor-made treatment? We're thinking that if we can see the subcategories, if it's more somatic, more dissociative, or more psychologic, I can recommend as a hospital to the community, this child is more somatic, maybe he needs a dance therapy. It will help him. This child is more anxious, because this is like the psychology subscale. Maybe he need oral treatment. So we think this can predict on even the way of treatment and tailor-made treatment. Thank you.
So now future research will focus on the correlation of MSDQ with child abuse in children. Okay, we're not there yet, but we're going there. You wanted to ask something.
What exactly do you tell the parents while you, because
I don't need to. I have doctor's privileges. I don't say anything. I just ask questions. After I finished asking about many other stuff, I just start to ask the questionnaire.
What? You don't ask permission from the parent to ask questions?
As a physician? No, I don't need a permission. No. For the questionnaires in research or in real life? In real life, I don't ask for permission. I was given the permission already. When they enter the room, and when they come to the hospital, they also sign but when they enter the room, and it's okay to ask any kind of history. This is part of the history. Or it's part of the, if you want, it's more part of the physical examinations, because when you use a questionnaire, you get something which is more objective. And when we ask for, when we ask question, it's more for subjective. Okay, so this is more objective because I get a clear answer. It's like sending someone to a chest X-ray if you want.
Can I? And it's a good question for us because, especially with children who've been abused, this is like we call it to wake the bears. So we looked for a questionnaire that we as practitioners can ask the child, you know, simple question like, are you tickling on the hands? Are you not dissociated? Or nothing like that. Something very physical or simple. Are you sitting in a class, you not remember anything? Just, so it's like simple question, and not to wake the bear, and then it can be, then it can give us a back for, or maybe it's sitting on dissociation. It means that maybe it's sitting on adverse child abuse, and this was like our thinking.
Perhaps to say some as a disclaimer. First of all, we rule out common pediatric diseases. If someone is coming with an abdominal pain to the ER, it's not the first thing I think of. It's there in the differential diagnosis, but it's not on the first spot. I'll first rule out appendicitis, Crohn's disease, I don't know, acute gastroenteritis, whatever. And then, after I've ruled them out, then I'll do the questionnaire. And again, if the questionnaire is positive, at first it comes with a feeling, but when the questionnaire is positive, I know I have to take a left turn. And if it's negative, then I probably should take a right turn and think it over.
And following yesterday's conclusion, I thought about to say that we couldn't do it by ourselves. If not the help of the research center, and Rachel came to us to the hospital and sat with us, so then we could promote our research. Otherwise, it wouldn't get out of that. No, I didn't say it because of your here. It's fine.
Shir is trying to say that we couldn't have done it without you. So this is what we're saying.
Okay, so we will go. Thank you.